Good morning, everyone. I'd like to welcome to our first session today. My name is Christina. I'm an exercise physiologist from Brazil. And on behalf of IFSO Integrated Health, I'd like to welcome to our session, promoting the preservation of lean muscle mass with metabolic and bariatric surgery and obesity management medication. Here, I'm delighted to have with me wonderful speakers today, and my friend Itka and Jorge from Chile.
Can we ask you, on your app, you've got an interactive program about asking the speaker. If you click on the program on the main menu, and you click interactive program, find the session, and when you click the interactive features button, you can ask your questions in advance, which will come up here, and then we can use that as a guide for the questions at the end, if that's okay? Okay. So, pardon me, to introduce the session, it gives me great pleasure to introduce my dear friend, Professor Christina. She's an exercise physiologist. She has a degree in strength training and health performance from the University of Sao Paulo. She's a personal trainer and functional trainer from the Cooper Institute. She's a member of the IFSO Integrated Health Education and Training Committee. She's an MDT specialist from the Brazilian Bariatric and Metabolic Surgery Society and currently works prescribing physical activity plans to pre- and post-bariatric patients. Thank you, Chris.
How can I turn? Oh, okay, thank you. So, good morning again. I would like to discuss with you today about how can we set proper goals for strength training that we can also call resistant training. So let me see. Where am I supposed to point it? Okay. So although recent data showed efficacy using obesity management medication in patients with suboptimal clinical response or weight recurrence, there is a concern about organs, skeletal muscle, and bones loss. So we know that this waste is like dangerous for metabolic diseases, frailty, and weight recurrence, again. So clinical trials demonstrated a significant lean mass loss, as you can see on the right side in red, where some are higher, are bigger than bariatric surgery, lean mass loss, and was compared to a decade or more of aging that causes an impact on the metabolism. And the most effective treatment we know is a combination of strength training and proper protein intake. But first, I would like to look at the terminology and measurement problem. Lean mass and skeletal muscle mass is often used synonymously, and sometimes fat-free mass too, leading to flawed interpretation. According to precise definition at tissue organ level, lean mass involves organs, connective tissue, water, and skeletal muscle, as you can see in the illustration. And fat-free mass involves lean mass and bones. compounding this issue, DEXA is widely used to measure body composition, but is not the best choice for muscle mass. See, furthermore, most studies didn't explain very well where they are measuring the body composition. They fail in describing in detail their methods. So we don't really know what body composition compartment is being assessed. Moreover, there are fat-free components in adipose tissue, which is around 15%, and you must take into account. So there is a risk of over-interpreting lean mass loss. Unfortunately, there are only a few studies using proper measurements for skeletal muscle, gold standard ones, that would be MRI, magnetic resonance, ultrasound, and tomography. That said, currently, we don't really know how much muscle is really lost, what is the acceptable muscle mass loss, what's the acceptable threshold for that, and we don't know if we are overestimating muscle mass over strength and body function, knowing that a leaner body doesn't need as much muscle as before the weight loss. If you remember, we've had a similar discussion about sarcopenia in the past, which now is considered a muscle disease with low muscle strain, overtaking the role of low muscle mass. So how about starting to focus on muscle health instead? And why we don't have studies investigating the impact of strength training in post-bariatric patients undergoing pharmacological treatment for weight loss, I'd like to share with you essential elements to improve strength and hypertrophy. And the first one is the load. High load exercise is a well-known stimulus for enhancing hypertrophy and strength, but it takes time to reach high load exercise safely. Luckily, the recent data shows that low load exercise can lead to similar increases in hypertrophy when performed to or close to muscle failure, thereby inducing fatigue. The training volume also matters. It seems to be a dose response for hypertrophy, characterizing multiple sets and multiple sessions per week as a top-ranked prescription. It's important to say that when volume load, and I know it's not maybe for your daily practice, but the volume load can be calculated multiplying sets by repetition by the weight lifted. So when volume load is equated, the results will be almost the same. For example, it doesn't matter if you perform 6 sets of 10 repetitions or 3 sets of 20 repetitions. In this example, with the same weight, you will reach the same results. However, for strength, starting from 2 times per week will lead to quick progress in the beginning. And here, I'd like to point out that although some studies show that bariatric patients are less likely to gain hypertrophy, gain muscle in the first 6 months after surgery, they can certainly gain strength, enhance the autonomy and quality of life. The third element is time under tension. Time and attention is one of the key components for hypertrophy. The longer the muscle is exposed to tension, the more muscle fibers will be required, will be recruited. So slower and controlled movements during exercise throughout the whole range of motion is a good choice. Exercise variety. Different exercise in multiplanar and multi-angle fashion improve neuromuscular adaptations. Likewise, changing the training plan periodically is paramount to avoid stagnation. These are valuable tools for manipulating the training according to our patients' preferences and still reaching our goals, the expected results, not miracle, but expected results. But lean mass loss is not the only side effect of pharmacological treatment that physical activities can help with. Clinical trials show that during the treatment with OMMs, they have noticed an increased heart rate. And we can improve it adding aerobic training. So in short, a comprehensive exercise program serves as a countermeasure for some side effects during OMM's treatment. Therefore, combining strength and aerobic training can mitigate muscle and bone loss, preserve or even improve strength and body function, provide better mechanical shock absorption, protecting the joints, provide better, enhance body composition, decrease cardiometabolic risk, provide more energy, more vitality, and less depression symptoms, improve cardiorespiratory fitness and weight loss, counteract increased heart rate from OMM's treatment, and best of all, diminishing the chances of weight recurrence. Accordingly, it's clear that there is an urgent need for high-quality RCTs with clear terminology, proper measurements, standard exercise training protocols. We really need that, mainly for strength training. Integrating combined exercise, meaning aerobic and strength training, is paramount when it comes for MBS and pharmacotherapy with a specialized professional, and focus on muscle health, strength and body function over muscle mass itself. So in conclusion, if we truly want long-term health after bariatric surgery and pharmacotherapy, we must go beyond weight reduction. The key is to protect muscle, preserve strength, and prioritize function. By doing so, we are not only helping patients lose weight, we are giving them the foundation for health, independence, and quality of life. Here, if you point your camera, you have the whole list of references. And I'd like to thank you for your time and patience with my accent. Thank you.
Thank you very much, Chris. Please, thank you for the questions so far. If you have any questions, please upload them on the app. It gives me great pleasure to introduce Professor Lee Kaplan. He's a professor of medicine and chief of the section Obesity Medicine at the Geisel School of Medicine at Dartmouth, director of the Dartmouth Obesity Care Center, and director of the Boston Course in Obesity Medicine. Professor Kaplan's research is focused on the role of the GI tract in the regulation of appetite, energy balance, and metabolic function, the mechanisms of action of MBS, and the genetic determinants of response to obesity treatment. Thank you, Lee.
It's a pleasure. Thank you very much for inviting me. And a little bit odd to talk about GLP-1 receptor agonists in the context of a session on muscle loss. So I'm going to try to integrate those two concepts together in this short talk. I think, as everybody knows by now, it doesn't matter what the type of therapy we use for obesity, whether it be a dietary therapy or a drug-based therapy or a device-based therapy or surgery, you still have the same broad distribution of response. The average response is at the top of the peak of these curves, but there's an enormous variability. Look at bariatric surgery itself. It goes from 10% weight loss all the way to more than 50% weight loss across this. And it's a smooth curve, suggesting that there's biology that sits behind that. Well, if you look specifically at gastric bypass, we talk about suboptimal weight loss as something less than what we expect. And if so, in 2023, had a consensus statement that suggested that suboptimal initial weight loss was either something in the range of less than 20% weight loss, or if the indication for the surgery was something other than weight loss, for example, treatment of diabetes or treatment of MASH, then it was inadequate response of the goal of the therapy, inadequate response to the diabetes, inadequate response of the MASH. But in addition, beyond the concern about where you draw the line, I've put a yellow box around maybe on this curve where we might say it's suboptimal weight loss. Here, suboptimal weight loss is 40 to 50% or less than 50% excess weight loss, which corresponds to less than 25% total weight loss. But it doesn't have to be there. We could be more stringent and move it over to the left. We could be less stringent and move it to the right. With our better therapies for obesity, our expectations for success continue to rise. So the second piece that we have to worry about is, of course, you could have initial optimal weight loss, but then you could have weight regain. And weight regain, as you know, on average is for a gastric bypass or a sleeve gastrectomy is about 25% over the first 10 years. Some people gain no weight, some people gain more. But what are the potential causes of that weight regain? And that would include environmental factors, as some of the ones shown here, particularly the institution of weight gain promoting or obesogenic medications, progression of the obesity itself, worsening obesity over time, continued exposure to our broad obesogenic environment. But there are also lifestyle factors. Pursuit of a more unhealthy diet after the surgery than before the surgery, simply because people say, well, I've lost all the weight, now I can relax. And that doesn't always work. Lack of exercise, calorie restriction diets, which can have the unfortunate effect of having a rebound. You get yo-yoing. So calorie restriction, it's not physiological. The body reacts with metabolic adaptation and pushes you above where you started. And then biological factors. We don't know if genetics plays a role in weight regain. We know it plays an important role in initial suboptimal weight loss, but we don't really know about genetics and weight regain yet. And then there's this concept of physiological memory, the idea that the body having had obesity has changed its regulation in the brain such that even when you treat, you don't fully resolve the problem. You don't, even under treatment. Yes, you lose the weight. Yes, you improve all the metabolic function. Yes, you do all of the secondary, you get all the secondary benefits. But over time, the body may push back to what it was like before the therapy, at least partially. And I call that physiological memory, but we don't really understand it very well. So just looking at progression as a major potential cause of weight regain, if you have, this is what the pathway of your particular obesity or a patient's particular obesity might have been, and you intervene with, say, a gastric bypass or a sleeve gastrectomy or an other bariatric and metabolic procedure, if all the patient does is follow the trajectory that that patient would have followed before, all they do is they follow it. This is even a little less than following it. And what you see here is the way I've drawn this, that corresponds to a 50% weight regain. It looks like a 50% weight regain, but we no longer call it weight regain. This is new weight. This is the new weight that would have occurred had the patient never had the operation. So, of course, the weight is going up, but it's really not weight regain. It's new weight gain from progression of disease, and it's important to distinguish that. Well, when you add medications, you can actually stem that. And here's a study of people having been treated with gastric bypass. They were given diabetes doses of liraglutide, so not enough to only causes about 4% weight loss. And you see that after the surgery, you get even more than a 5% weight loss, or about a 5% weight loss, suggesting that surgery plus the drug, this GLP-1 receptor agonist, actually does better than the drug alone. The drug can do better after surgery, even though the patient's already lost about 20% of their weight. And so if you look at the percentage of people who got at least 5% weight loss on the liraglutide after gastric bypass, it was about 50%. In the placebo, of course, it was much, much lower. In the second study, the Bari-optimized trial, this is a study of people who did not do well with bariatric metabolic surgery. Some of these patients had sleeve gastrectomy, some of these patients had gastric bypass, but they had less than 20% total body weight loss after the surgery by the time they reached plateau. Adding liraglutide now at a higher dose, this is 3 milligrams instead of 1.8, what you see here is about an 8% weight loss. What does liraglutide do without surgery? About an 8% weight loss in people without diabetes. So what it says is that even though these patients have already had the surgery, even though they haven't responded as well as we would have liked to the surgery, they are prepared to respond normally to the liraglutide on top of the surgery. They add together, showing that they're independent of each other. Now, the reason I mentioned at the beginning of my talk that this is a funny place to talk about this again, because we're talking about muscle mass, I want to show you some new data that were presented this year, not yet published, at the American Diabetes Association meeting about 2 months ago. And that has to do with a new drug and a new mechanism, not an incretin, called bimagrumab. Bimagrumab is an inhibitor of signaling of myostatin by having an antibody to the target for myostatin, the receptor, which is the activin receptor 2B. And so I want to show you, this is a little bit of a complicated slide, but it's my last data slide. I want to show you the results of a complicated phase 2 study of combining semaglutide, obviously you know this, a GLP-1 receptor agonist, with bimagrumab. So let's just look at the data here. Now I'm going to have to orient you. Whoops, why is this not going? Here we go. I have to orient you to this study. It's complicated. So in this study, some participants were given bimagrumab at a low dose of 10 and a high dose of 30. That's shown in blue. Some people were given only semaglutide at a low dose of 1.0 or a high dose, an obesity dose of 2.4. That's shown in green. And some people were given combination, and all 4 possibilities: low dose bimagrumab, high dose semaglutide, the opposite, low dose of both of them, or the high dose of both of them. And what you can see here is that the weight loss with bimagrumab is not as good as semaglutide in this population, but it's not too bad. But when you combine the two, you can see here that the average weight loss of the combination at the highest doses was 20% weight loss, compared to the highest dose of bimagrumab alone was less than 10%, and for semaglutide just under 15%. So there is some additivity just in weight loss. But the other piece of bimagrumab is that it tends to protect or preserve muscle mass. And so let's look at muscle mass then. And so if we look at muscle mass, with the bimagrumab, 100% of the weight loss was due to fat loss because there was muscle gain. So of course you can have none of the weight loss being from muscle loss because there was no muscle loss. And if you look at semaglutide, it was about 70% fat loss and about 30% muscle loss, or not muscle, but total, as we heard in the last talk, total lean mass loss. And if you add together the bimagrumab and the semaglutide, no matter what dosing you use, you drop that 30% loss of muscle, or 30% of the weight loss is from muscle, down to about 7%, as you can see here. So the combination not only, if you look at the left side of this slide, not only gives you more weight loss, but it protects the muscle mass. And so that suggests that maybe the combination of these two could be. And this is now going to be studied further because this is a phase 2 study. There are only a few hundred patients in the study, and so this needs to be pursued further. Safety issues have been raised about bimagrumab. In particular, there's a transient elevation of liver tests. There's a transient elevation of the LDL cholesterol. They both come down after a year, but we have a lot more to do before we can conclude that this combination, or any combination of a GLP-1, which is known to cause muscle loss, with bimagrumab, may or may not turn out to be a way toward the future. We just simply don't know at this point. So from a practical perspective, I think the first thing to comment, since I just talked about that, is we don't really know how much muscle loss is the appropriate amount of muscle loss. People with obesity have more muscle. They have more lean mass. So if somebody has a BMI of 34 and they have more lean mass, and then they lose muscle mass, and they end up at, let's say we treat them and they end up with a BMI of 24, do they have more, less, or the right amount of muscle for somebody who was always 24? We just don't know. Do they lose? Yes, we see all these curves. We say they lose muscle. That's expected. They also lose some bone density. That's also expected. Nobody has yet done the study that determines, is it appropriate or is it inappropriate? Is it too much, too little, or the right amount of loss of lean mass? Obviously, those studies are underway and need to be reported. So when we think about it from a clinical perspective, and we think about combining medical therapy with surgical therapy, first of all, combination of medicine and surgery is very effective. We've seen that before. It works best for suboptimal initial weight loss, but it also works for weight regain or gain of weight after initial good weight loss. We want to pursue a stepwise therapy. Today, that stepwise therapy is either used tirzepatide or semaglutide first, but in the old days, we didn't know which drug would work best for which patient. So we would try one, maybe add one, maybe substitute one. And in the next 3 to 5 years, we're going to be going back to the old way of doing it because we won't just have 2 GLP-1 receptor agonists, we will have 5. And when we have 5, they'll all be a little different. Some will have glucagon, some will have GIP. And so we'll be back to the situation where we try something, and see if it works, great. And if it doesn't work, we'll have to try something else. We'll have a lot more choice with these newer drugs. We want, because we're going to be testing that out and because different people respond differently to each drug, we want to test these drugs, see what they do, bring the patient to plateau, and if you either have to add a drug or substitute a drug, you can do that at that point. But because there are no good predictors of which patient's going to respond to which drug. So we'll go back to the situation where you're using trial and error to figure out the right combinations. But at the same time, I showed you that one early study with bimagrumab, but there are many drugs in that category that are going to be tested. Some of them may be better, some of them may not be effective. And so over the same period of time, over the next 5 years, we should be seeing an opportunity to really start to manipulate not just weight, not just fat mass, but where the fat is and muscle mass as well. So with that in mind, just remember that whatever we do to treat obesity, we have to anticipate lifelong therapy. Whether that's good or bad or in between, it's lifelong therapy for a chronic disease. Thank you very much.
Thank you, Dr. Kaplan. It's a very wonderful lecture.
Dr. David Krill, licensed physiologist, certificate clinical exercise physiologist, registrado en, ¿sí? Certificado en diabetes care, education specialist. ¿Por qué? No.
Clinical psychology.
perfect.
All right, so, and a PhD in clinical psychology from Louisiana State University. He currently works at the Cleveland Clinic in the Department of Endocrinology, providing behavioral health services and conducting physical activity research. Thank you, David.
Thank you, and thank you for the invitation to speak today. So we're talking a lot about physical activity today. We're talking a lot about muscle mass preservation, strength training. I think everything that we talk about today probably won't matter so much if we can't get people to do some of the activities. Now, we might have a medication someday that preserves muscle mass, but what's that going to do with function, quality of muscle? What are some of the other benefits? So I think there's always a place for physical activity. There's always a place for resistance training as well. So I'm going to touch on a few things and try to do this in 12 minutes. All right. So there are many theories related to motivation and physical activity. So the list here, I'm going to show you graphically just a little bit to make it maybe a bit more interesting. If you look at like self-determination theory, we know that autonomy is really important, that this is my choice to do. I'm not being told to do something, but this is my decision. I am the decider, so to speak. It's related to things that are important to us. So our family, right? I want to have the strength to do things and go places and not be injured, and I know strength training can help with that. Competence, and competence can be related to lots of things, like our past experience, our knowledge, the achievement of goals over time. At the center of motivation usually is kind of perceived pros and cons. Expectations are really important. What do I expect will happen if I do this? What do I expect will happen if I don't do this? And what's the likelihood of those things occurring? So the last thing is social norms. So I was thinking about this. Some of you are old enough to know what parachute pants are. Anybody, MC Hammer? Yes, okay, good. No one's wearing parachute pants today, right? I don't see any parachute pants. Why? It's not in style, right? It's not maybe appropriate for this conference. Social norms influence what we do. So that's an important component of this as well. There's another theory called energetic cost minimization, and it's really depicted very well with this slide on this picture on the left, where you have this trail. It's very nice, it's brick trail and concrete, and people take the easiest route. We're kind of wired to figure out ways to do things more easily. Electric garage door openers. This middle picture I took at a conference. I'm not going to say which one, but we're all sitting around like we are today, and then talking about physical activity and getting more physical activity. And then you go to the escalator, even going down, people take the escalator. The stairs are on the far right. They take the escalator and they ride it. They don't even step down it, right? I'm not judging people. I'm just saying it's kind of normal to say, oh, this is the easier way to do something. And that's something we're always battling against when it comes to physical activity. Other research is coming out talking about these automatic affective evaluations versus reflective evaluations. So if I say to you, hey, you want to meet me in the morning to do some strength training, you have an initial thought. It might be positive, it might be negative. And that initial thought can affect things. Versus you might have a reflective evaluation. Oh, yeah, I'm getting older and I'm feeling weaker. This would be really important. Maybe I will do it, right? It's kind of like if you think about every month when you get your paycheck, or every 2 weeks when you get your paycheck, why don't you put 5 to 10% into your retirement? You're going to have 5 to 10% less money every month. I don't want to do that. I want to buy new shoes, or I want to buy new stuff. But the reflective evaluation is, I want to live comfortably in my retirement. Pleasure. So I think this is really important. This is really important for our patients, especially, who maybe don't have a lot of experience with physical activity, making it more enjoyable. I'm not going to go through the highlights of this study, but basically, they had people, I will go through, I guess, the highlights, but not the specifics, had people evaluate pleasure and how tolerable they were to kind of intensity. And then they had them focus on the pleasure of the activity as they were doing it, so that they enjoyed the activity more when they did it. And then they showed that for the 8 weeks following that, they had more follow-up sessions. Again, a short-term study, but I think it's important. we know that our patients have a lot of obstacles, unique obstacles. You know, maybe they were teased related to physical activity. They just have a sour taste in their mouth when it comes to physical activity. They have pain. They've had practitioners their whole life relate physical activity to the scale. Diet and exercise is one word, and the exercise piece is punishment for not being able to control their eating. And that's in their mind. It's like, oh, if I'm not doing well with one, I'm not doing well with the other. Maybe just not enjoying it. It's hard. Good thing about physical activity, as Dr. Kaplan was saying, we know that people with obesity tend to have more muscle mass. So if we catch them early, this is a little bit easier to do. They're not supporting their weight a lot of times if they're doing like machines or dumbbells or something like that. Now, if they're doing body weight exercises, they can do those. That's actually probably a good way to start for many of our patients. But this might kind of help counteract the difficulty that people have with more aerobic type activities. This was a qualitative and a quantitative study, and I really pulled it out because of a quote that was put in the qualitative piece. This lady, after she finished, she said, well, for the weights, I would just go to the girl section of the gym. You know, the little hand weights. Okay, I don't think there's a girl section of the gym, by the way, but she said this, right? I just didn't feel comfortable in a gym doing weights. I was comfortable here, but in the gym, I felt that everyone was looking at me. I'm still overweight, you know. You guys wanted me to do well. I did not get that from the gym people. The equipment was different. I just didn't feel comfortable. This is what we encounter a lot. We do these studies. People feel comfortable in the study, but when we get into the real world, there are many more challenges. I just realized I'm really short, and I see the timer right there. So, okay. All right. So in summary, motivation is very complex. And if anyone says, just do this, this is the answer, you probably can't believe them. Motivation is very complex. People are complex too. I also think motivation maybe gets its unfair share of the attention. How many of you every day wake up and you say, cannot wait to go to work. Ooh, this is the best thing ever. I can't wait to. I think I'll get up earlier to go in early. How many of you feel like that every single day? Oh man, nobody. Do you go anyway? Most of the time you go anyway. So within motivation, now motivation got you your degree, right? You're like, I want to do this. I'm inspired to do this. But at some point you made a commitment to your job, or you make a commitment to a relationship or your faith or whatever it might be. And that leads to an identity. You guys identify as dietitians, nutritionists, exercise physiologists, physicians, nurses. You have an identity. And that's powerful to create a lifestyle. That's what we're shooting for when it comes to physical activity and strength. We want people to see themselves as, yeah, I'm a person who does resistance training. I'm a person who exercises. That's what we're aiming for. We can't just stop with the motivation. We get someone really motivated, but all the other pieces aren't in line, it's not going to work long term. One thing that we're doing at our clinic, we just kind of finished the first round of a pilot, haven't analyzed any of the data. Well, started to analyze some of the data. But we're looking at all the psychosocial, not all, but many of the psychosocial factors that are related to physical activity. So knowledge, experience, body image, the ease at which they can do things, these weight-focused beliefs that I was talking about. Identifying their strengths, trying to use that in our counseling, identifying the challenges, and trying to work with those as well. So it individualizes, not just individualizes an exercise prescription, frequency, intensity, time, and type, but really tailors our intervention with the person. We want to meet the people where they are. So Prochaska, DiClemente, probably many of you are familiar with the trans-theoretical model or the stages of change. We want to meet people where they are. If someone is pre-contemplation, not even thinking about exercise, I'm not going to say, okay, I want you to do 30 minutes, 5 days per week. It's like, tell me a little bit about why you're here today. Who recommended that you come? Okay, what do you think about their recommendation? We're just having a conversation about this. Oh, do you have a wearable? Oh, you have a wearable. Would you mind kind of just checking on that? When you come back, we'll take a look at it. That might be where we're starting with someone in this pre-contemplation or contemplation. If we prescribe and they fail, that just makes them feel like I've failed again, right? So some steps to consider. All throughout these steps, I would say we want to consider the values of the person and their experience with their physical activity. But we're going to talk about the benefits of physical activity with them, assess their knowledge, ask them to experiment with curiosity. Why don't we try this? And I want to hear what your experience was like. We want to promote enjoyment, small goal attainment. Oh, you achieved that. That's great. You did 500 more steps this week compared to the week before. We want to deal with the barriers, look at competence and comfort over time. We want to eventually develop a routine and a sense of mastery. A sense of mastery is powerful, no matter what it is. Checking something off the list, and eventually we're trying to seek habit formation. I'm not going to speak to the function side on the right-hand side because I think Chris did an awesome job doing that. But we want to make sure that we are dealing with some of those functional things that are goals of the patient. But how do we make it more enjoyable? Maybe this will come up more in the discussion, but music, friends. Some people like the feeling of pumped up muscle, that muscle fullness. You guys, I see some people. Yeah, you probably like that. It feels good to have this muscle pump. Group exercise. Just achievement. Achievement is motivating in and of itself. Gamify. Some people really like to gamify their physical fitness. Strength snacking. This is something I do. I work from home 3 days per week, and I've done this before with a half a deck of cards. Each suit, so clubs is body weight squats. You pull out a card with a number. You do that many, and you go through half the deck throughout the day. Maybe once every 45 minutes, once every hour, you do a set. Something to get people started. Doesn't take a lot of extra time. They need a break during the day anyway. They don't have to set aside time to do a strength training bout. So some take-home messages. Please individualize your approaches based on your assessments of the main strengths and challenges of your patients. Understand your patient's history and tendencies. That's really powerful. The best predictor of future behavior tends to be past behavior. How has this worked for you in the past? Are we going to fall into that same rut? How can we do it differently? Explore the benefits and how those benefits connect to the values of your patient. Think outside the box with cardio and resistance. We have it in the prescription. 150 minutes of moderate physical activity, 2 days or more of resistance training. We can combine these. There's no reason we can't combine these, especially for people who are new to this. Okay, they don't want to set aside another time sometimes to do that. We can combine them. Consider resistant snacks, as I mentioned. Prescribe enjoyment. Part of our prescription is to help people find this more enjoyable. I don't think we often think about that. We should have the FIT-E principle: frequency, intensity, time, type, and enjoyment. And don't rely solely on your initial assessment. One thing that we're learning through our study is that we assess them initially when they're not doing physical activity. When they start to try it, they have new insights about what their challenges and strengths are. Thank you so much.
Thank you. It's a wonderful lecture. And I'd like to go to the next one and call my friend Sylvia from Brazil. She is PhD and Master of Science in Human Nutrition, postdoctoral project on microbiota and weight regain among bariatric patients, President of the IFSO Integrated Health, Coordinator of the Nutrition Health Commission for the Brazilian Bariatric and Metabolic Surgery Society, researcher at the University of Brasília, Brazil, currently works in clinical practice at Gastronutrição Bariátrica. Welcome.
Thank you. Thank you for the invitation. I'm glad to be here, and I love it to see the first speakers and learn too much. So my presentation, the title actually is a question. So is there any nutritional strategy to prevent muscle mass loss during the use of obesity managing medications? So I'm going to discuss this during my presentation. I have no disclosures. So with the use of obesity managing medications, we have some advantages and some challenges. So as advantages, the medications are effective in terms of weight loss. Because of that, they boost self-esteem. The weekly doses improves adherence. And as challenges, we have limited clinical knowledge on nutrition and lifestyle change. We need some studies, more studies on that way. We have some gastrointestinal side effects. We have the risk of inadequate nutrient intake. We know that there is a high cost and discontinuation rates, and also potential muscle mass and bone density loss. And I will focus my presentation on potential muscle mass loss. When we talk about potential muscle mass loss, so is the concern justified? So as we saw on the first speakers, we have a literature on that, and depending on the evaluation that we have concerning muscle mass loss and concerning the methodology and the way you are evaluating, if it is a muscle mass loss or lean mass loss, it can go beyond 40% to 20 and 10% of lean mass loss with the use of obesity management medication. And it is comparable to 10 to 20% of age-related muscle mass loss. So this study was done with tirzepatide, and patients were evaluated for 72 weeks, and they lost 70 kilograms, and they lost 6 kilos of muscle mass, and it is comparable to 10 years of human aging on skeletal muscles. So is this concern justified? When we compare the muscle mass loss with the obesity management medication compared with the other treatments for other diseases such as cancer, so the loss with the obesity management medications with tirzepatide and semaglutide was higher than treatments for cancer. So we can say that the concern is justified. So the decrease in muscle mass can lead to sarcopenic obesity. That sarcopenic obesity is two diseases together, the obesity and the sarcopenia. It can hinder quality of life. It can lead to lower weight loss. It can also lead to weight regain due to decreased basal metabolic rate. And when we are talking about patients submitted to metabolic and bariatric surgery that will be using obesity management medications, we have more causes for we to be concerned about sarcopenic obesity, and also causes for decreased caloric and protein intake. So these patients will be consuming less protein. Also, there will be decreased adherence to the protein intake, and also decreased caloric intake, and also probably decreased physical activity, inflammatory comorbidities, and aging that everybody is exposed to this. So this can lead a higher risk of presenting sarcopenic obesity. For us to talk about sarcopenic obesity, we should talk about screening for body composition and sarcopenic obesity. We have seen, Christina made a very good job talking about that. We can't have access to the gold standard most of the time, so we have different methodologies. Some of them are very expensive, but they have a high precision, they are more accurate, some of them. Most of the time we use the DXA, and clinical usage, you can use biological impedance. It is not accurate, but it gives you a trial how the patient is going. But the most important thing is for sarcopenia, we should access the appendicular lean soft tissue mass that we can calculate appendicular skeletal muscle mass. And this data comes with the XA, and also we can calculate with the biological impedance if you have a multi-frequency one. Besides that, when we also calculate strength and muscle mass, we should evaluate we should use some tests, and the ones that are most recommended is the 5 times C2 stand test, that we have this cutoff point of doing that in less than 15 minutes, 5 times, and hand grip strength, that the cutoff points are shown here, 16 kilograms for women and 27 for men. So recent data made a big review on that, and they recommended to do not use body composition alone to screen for sarcopenia, and do not use just physical function evaluation alone. So we should use both and probably adjust for body weight. And we have also a recent guideline on sarcopenic obesity evaluation that recommends to use evaluation of muscle function and also body composition, the screening for sarcopenic obesity. So now talking about preventing excessive muscle mass loss and knowing that we should avoid the sarcopenic obesity scenario. So we have 2 cornerstones for preventing excessive muscle mass loss. The first is adequate protein intake, that is my area, and the second is strengthening exercise. To show all of them, I will try to use randomized clinical trial studies that are a level of evidence 2. This is not a clinical randomized trial, but I will try to show some strengthening exercise studies and muscle mass loss and muscle mass loss or not muscle mass loss during this phase. So this is a study with a caloric restriction diet and resistance training. So in the end of this study, patients that were submitted to caloric restriction diet and resistance training, they didn't lose lean mass. This was a study that was a randomized trial one. Patients were submitted to liraglutide alone, exercise alone, and then liraglutide with exercises. And patients submitted to exercise with liraglutide didn't lose, they lost more fat and they didn't lose fat-free mass. So taking this to account, this study hypothesized that if patients were submitted to OMMs, obesity management medications, with strengthening exercise, they should lose more fat and do not lose fat-free mass, and it can lead to a better results in terms of do not presenting weight regain in the long term, but we need results to prove that. And in terms of exercises and results in lean mass, the modality matters. So as you can see here, strengthening exercise have a better results in terms of lean mass. And we have the recommendation of 150 minutes per week of moderate to vigorous exercise. But we have seen some specialists on that here. So focus on nutritional strategy, that is my specialty. So we have a lot of recommendations when patients are being submitted to obesity management medications. However, I will focus my presentation on protein consumption and also some vitamins and mineral recommendations. So as a protein intake for patients that are in treatment with obesity management medications, we have the recommendation of the minimal amount of 60 grams per day, and we can achieve 1.2 to 1.5 grams per kilogram of ideal body weight per day. We can use like meats, poultry, fish, eggs, and low fat daily. We should distribute throughout the day to maximize protein synthesis or do not lose muscle mass. We also can use protein supplements if needed, and if you're using, just be aware that the protein you are using has at least 2 grams of leucine. This can help your patients to do not lose muscle mass. Or you can use also oral nutritional supplements, and we have a very new paper that is just published. The key point on when you're using protein supplements is adherence, and this paper shows that patients adhere more, had adhere more when they were exposed to a liquid protein supplement. So this can be an option if your patient is not adhering to a powder protein, for example. In terms of nutritional deficiencies, we have this paper that have shown that patients that were submitted to obesity management medications, they have shown some nutritional deficiencies by the end of a year. So if your patient is, was submitted to metabolic and bariatric surgeries, we know that he must use multivitamin, but if it is not, consider using a multivitamin, because most of these patients will present some nutritional deficiencies because they are consuming less than 1,200 calories per day, and so they are in higher risk of presenting nutritional deficiencies. This study have shown that patients were presenting by the end these nutritional deficiencies: vitamin D, iron, folate, thiamine, and B12. So in summary and conclusion, my question is there any strategy to prevent muscle mass loss? Yes. Is there a nutritional strategy to decrease the risk of muscle mass loss? We need more studies in this area. Body composition should be evaluated before and during the treatment with OMM, so we can manage and we can increase protein and deal with this probability of losing muscle mass. Adequate protein and physical activity can help to mitigate muscle loss. Mitigating muscle loss may prevent weight regain, and consider multivitamin with reduced caloric intake is another recommendation. So thank you.
Thank you, Sylvia. Very elucidating. I'd like to call Rejane Marcon, talking about the impact of weight cycling on severe obesity and mortality. Dr. Rejane Marcon from Brazil works at Hospital de Clínicas de Porto Alegre and Studio Rejane Marcon, exercise physiologist, specialized in sport training and psychomotricity. He's a master's degree in cardiology, health science, PhD in medicine, surgical science, former president of the Physical Health and Rehabilitation Center of the Brazilian Society, member of the IFSO Integrated Health Education and Training Committee. Welcome.
Thank you. I thank you the invitation, and I talk about the impact of weight cycling on severe obesity and mortality. Don't have disclosure. And the obesity increase in the world, and in consequence, increase the desire to weight less, increase the weight loss attempts, and the failure to reach weight loss goal or maintain weight loss. And this leads to frustrations and reduce adherence to weight loss program. In consequence, increased weight regain and increase the obesity prevalence. What is weight cycling? These are intentional weight loss attempts followed by unintentional weight regain. It's increase and decrease the weight, and know the yo-yo dieting. And know that 8% of individuals who lose weight have difficulty keeping it off. And the literature, I reviewed all literature, and it is difficult to compare risk and benefits across studies because the lack of standard definitions for weight cycling and complexity of weight cycling patterns and limitations in the design and methods of analysis of weight cycling in the literature. And now I show you what the literature tells us about this. So the experimental studies, the results are similar though no in human studies. And what is the impact of the weight cycling on health and in obesity? The weight cycling toll it is associated with increased metabolic abnormalities in adipose and pancreatic tissue, and in the cardiovascular and immune systems. And in severe obesity, increase the risk of cardiovascular metabolic disease, atherosclerosis, and mortality, and increase the risk of anxiety, depression, type 2 diabetes, hypertension, cancer, and high mortality. And the literature, when compared the gender, the women are more susceptible to weight fluctuations when compared women and men. In relation to the body composition, the repeat stress on the body caused by loss and gain disrupts metabolic homeostasis, further contributing to changes in body composition. And lean mass decrease during the weight loss period, and fat mass increase during the weight recovery period. And the greater the number of times the weight fluctuates, the greater the loss of lean mass. And this imbalance and loss of muscle mass may represent a risk factor for sarcopenia and sarcopenic obesity. And this study compared 3 groups and analyzed the cyclers, the number of the cyclers, no weight cyclers, mild weight cyclers, and severe weight cyclers. And in the results, these studies, that when comparing the severe weight cycling with those without weight cycling group, the participants who performed severe weight cycling had an increased risk for low muscle mass, low muscle strength, and developing sarcopenia. And these studies is analyze meta-analysis of association between intentional weight loss and mortality risk. These meta-analyses are observational studies, and the results, this meta-analysis, that weight variability is associated across weight BMI categories with increased risk of 41% of all-cause mortality and 36% of cardiovascular disease mortality. And individuals with the greatest weight variability increase risk of any coronary event, major coronary event or death, myocardial infarction, and stroke. And the highest risk was observed in overweight and obese individuals. And this meta-analysis analyzed randomized clinical trials, 5 meta-analyses, and only one reported a statistically significantly lower all-cause mortality risk associated with weight loss. But these studies have, this meta-analysis is not are inconsistent and inconclusive on intentional weight loss and mortality in different treatments, clinical or surgical treatments. In one, this meta-analysis analyzed just one study. And this results is inconsistent. And the exercise. I analyzed this meta-analysis and the results. Increased cardiorespiratory fitness is associated with a lower risk of cardiovascular disease and all-cause mortality regardless the BMI. Individuals with overweight or obesity, all-cause mortality reduced by 30% up to 60% when we increase fitness level, from inadequate or low fitness to active or very active fitness. This is dose response. When you increase the volume, the durations, and the intensity of the exercise, you can increase the benefits. And look, this in red is the group fit, and blue, the group unfit. And look the difference in all-cause mortality and cardiovascular disease mortality in the groups. And among others, the fat mass and the fat-free mass have opposite associations with mortality, and high levels of hand grip strength and knee extension strength are associated with a lower risk of all-cause mortality. And this studies when compare the treatment. One treatment, the emphasis on weight loss, and other treatment, weight neutrally and exercise. And look, the treatment that included exercise reduces more significantly all-cause mortality, improvements without weight loss, the cardiometabolic parameters, and related to the weight cycling promote less frustrations, and the adherence to intervention is better. And related to the health cost, the reductions up to $27,000 per year. So, this is important message. The physical exercise does not add cost to treatment, but it adds value to the treatment. This is important. And in this study, when analyzed the strategies for minimizing muscle loss during the use of the incretin mimetic drugs for treatment of obesity, when you, during the treatment, reduce the appetite, and this reduce the body weight and reduce the body expenditure. When you interrupt the treatment, increase the appetite, increase the energy intake, and reduce the energy expenditure. In consequence, reduce the muscle mass and occur the reduction in basal metabolic rate. And this increase the risk of weight regain. So this is important exercise too for this, but regardless of the treatment, when it is interrupted, a new weight gain cycle begins. We treat a chronic disease, and the treatment, this is necessary continued treatment. In summary, the exercise contributes to weight maintenance and reduce the risk of weight cycling. Even if your weight fluctuates, exercise promotes metabolic, psychological, and cardiovascular benefits. And evidence suggests that when the obesity treatment is accompanied by supervised exercise, adverse effects that occur after treatment this continuum can be mitigated. We know that weight fluctuation brings no health benefits, but patients with severe obesity face this problem throughout their lives. And this failure to maintain weight loss is perhaps the main reason they seek bariatric surgery. And obesity treatment needs to be ongoing. And we need to offer different strategies for continued and successful treatment. And about exercise, this article I and other professionals in the world published in 2023 about the role of the exercise professional in the metabolic and bariatric surgery. This professional is important if I want to prescribe exercise for these patients, adequate, personalized. So it's adequate for these patients. I need a professional inside the bariatric surgery team. This is hospital in New York and my contact, and thank you.
Thank you, Regiane. It was an excellent point. We have time for 2 questions. And the first one is for Dr. Kaplan, please. Do you think there are still risks associated with weight cycling if a person, I'm sorry, this is not for Dr. Kaplan, this one. Is there any data regarding cancer risk with treatment using monoclonal antibodies plus GLP-1 agonists?
Can we turn this on? Oh, yeah, it's on. So right now, no, there's nothing positive or negative. There haven't been any signals. So far, we've been pretty lucky that that neither the drugs that are being evaluated nor the drugs that we're using in clinical practice have an elevated cancer risk. The only one, of course, that we know for GLP-1 receptor agonists is MEN2, multiple endocrine neoplasia 2, which is associated with medullary thyroid carcinoma. But that's an incredibly rare thyroid cancer, and so that's a contraindication to its use. When you add 2 together or anything else, so far no signals, but these are all small studies, few hundred people. When we get to the phase 3 trials, for whichever ones go to phase 3, we're talking 3,000 to 6,000 patients in the trials, and then we really have the opportunity to make sure that there's nothing there.
There is... Don't get comfortable. This one? No. No? Okay. At what point, Dr. Kaplan, at what point after surgery do you start drugs considering that surgery was not successful?
So this is a critically important question, and I think the patterns are going to change back to what we used to do before we had GLP-1s. Because different patients will respond differently to every therapy. You saw those curves where some people respond very well and some people don't respond very well. What we do is if somebody doesn't do well initially, so they have suboptimal initial response, either because they don't lose enough weight or because their complications don't improve enough, whether it be sleep apnea or it be diabetes or whatever. Then what we do is we wait until they get to plateau. Now, some people have wanted to move a little faster than that because they say, well, let's look at the shape of the curve. But the problem with the shape of the curve and the amount of weight loss and speed of the weight loss is it goes up and down. You see, you get some weight loss, then you stop, and you get more weight loss, you stop. So you don't really know if you're changing anything by adding the medication. Once you get to a plateau and the weight is stable even for a month or 2, you then can say, did the new drug work? Because you really not only have to say who needs to have additional therapy, but does the therapy work? Because you're committing the patient to perhaps lifelong therapy, And if you want to commit the patient to lifelong therapy, I want to know with 100% or close to 100% certainty that the drug worked. So what we do is we wait until stability. Now, if we're talking about weight gain, after there's been stability and let's say the initial weight loss was fine, but then over time the patient starts to gain weight, we will look for a pattern of stable, of regular weight gain, not 5 pounds or 2 kilograms, but we're looking for over a period of, say, 3 or 4 months, weight is starting to go back up. That's when we would think about restarting or starting a new medication. So in those kinds of situations, there's no real answer because now the weight is going up. You don't want to wait too long. On the other hand, you want to make sure that the weight is really going up. And people's weight fluctuates. And if somebody gains 1 kilogram, we're not going to do anything. If they gain 5 kilograms, we probably will do something.
Okay, thank you. I'm so sorry we have to finish the session. And thank you for your attention. And we'll be again here at 9:30. So you have 10 minutes. Thank you.